Good afternoon. My name is Donna Grande, and I'm the CEO of the American College of Preventive Medicine. ACPM is a nonprofit medical specialty society with a mission to advance the practice of preventive medicine and support preventive medicine physicians trained in prevention and population health. Preventive medicine physicians have long been part of the backbone of America's public health workforce. Trained in both clinical practice and public health, these essential licensed physicians sit at various intersections of our healthcare system, working to support patients and communities with population health strategies and interventions, advancing the science of disease prevention, and training the next generation of physician leaders. In the following presentations today, you'll experience a small sampling of the incredibly diverse work of preventive medicine physicians and the settings in which they practice. While disparate in their practice settings, the skills and contributions of preventive medicine physicians make are uniform and united by a singular purpose: to help patients, communities, and populations live healthier lives by preventing disease and the consequences of disease. During the next 90 minutes, you'll hear from three experts in preventive medicine: Dr. Tinnette Krause, ACPM's current president and associate provost of Tulane University in New Orleans, Dr. Chris Purnell of University Hospital in New Jersey, and Dr. Linda Ferry of Loma Linda University in California. I will introduce each of them as they step up to speak, so you'll learn more about their bios at that point in time. Please know the session is being recorded and will be used for multiple purposes following today's session. And we ask that you please keep your questions to a minimum, given the number of attendees for today's session and the time that we have available following each speaker. As you hear their speaking and you hear each of the talks, please be sure to use the chat to post your questions. We will be moderating the questions and be sure to bring them forward. So we look forward to that. So our first speaker that we have for today is Dr. Tinnette Krause. I've had the good fortune of working closely with Dr. Tinnette Krause for over the past few years in her role as president-elect, and now since May as president of the ACPM Board of Regents. In her day job, Dr. Krause is the associate provost for health sciences, the associate dean for public health and medical education at Tulane University School of Public Health and Tropical Medicine. She's a physician scientist who humbly leads and serves as principal investigator on several NIH-funded clinical research trials and clinical trials, R01s, R38s, and the sort, focused predominantly on hypertension management, sex differences, and health disparities research in chronic cardiometabolic diseases. She is nationally and internationally recognized for her research in medication adherence to antihypertensive medications. Today, she will share highlights of her research and speak to the important role preventive medicine physicians serve to mitigate the onset of chronic disease, specifically cardiovascular disease. Thank you, Dr. Krause.
Okay. Thank you, Donna.
You'll want to be sure that we have your camera on so we can see you.
Mm-hmm. Pulling it up. Well, Donna, thank you. It is truly a pleasure to participate in this briefing today and to highlight examples of how preventive medicine doctors are leading new scientific discoveries, engaging in community participatory research, implementing evidence-based practices into clinical and community settings, and training the doctors and the medical leaders of tomorrow. To begin, it's important to recognize that preventive medicine physicians, many of whom focus their professional activities in academic health centers, are committed to advancing science and knowledge to improve the health of individuals and communities through prevention. in conducting translational research from the bench to bedside, from bedside to curbside. And that includes across the lifespan, including infants all the way to elderly, and ensuring health equity across a variety of groups: age, sex, gender, race, culture, geography, disability, and veterans. And you'll hear a little more about this in the other presentations today. And also training the next generation of leaders through ACGME accredited residency programs in preventive medicine, as well as other career development grants and contracts that are funded by NIH, CDC, and the like. To put this into perspective, in light of the clinical and public health challenges we are facing in the US currently, this slide lists the leading causes of death in the US reported by the CDC in 2020. At the top of the list is heart disease, followed by cancer, and then COVID-19. What these all have in common is that premature death and unnecessary pain and suffering with these diseases can be averted in most people with available and evidence-based preventive and therapeutic tools, such as routine vaccinations, blood pressure control, annual mammograms, etc. The catch is you have to have access to them and you have to use these tools. And while it's important that we are responsive to the emerging crises like the COVID-19 pandemic, it's also important that we keep our eye on addressing the underlying health conditions that are prevalent in our country and contribute to low health resilience, leaving our communities at high risk for poor outcomes. As you know, high blood pressure is a key modifiable risk factor for cardiovascular disease and can be managed with lifestyle modifications as well as proven antihypertensive medications. They've been demonstrated in randomized trials. In this figure, you can see on the right that high rates of high blood pressure in the Deep South, with high focus on Louisiana, Mississippi, and Alabama, essentially defining the stroke belt. And those living in the stroke belt also suffer the greatest burden of cognitive impairment. In these studies that observe people who have high blood pressure, what's very clear is that lower blood pressure reduces death from stroke, from heart and vascular disease, across all adult age groups. And we look at the rigorously conducted clinical trials to evaluate the benefits of low blood pressure. The results are the same, with blood pressure levels that are lower than the standard treatment threshold showing greater benefit in reducing cardiovascular risk. In this slide, the systolic blood pressure intervention trial set out to define whether or not this lower target of less than 120 millimeters of mercury systolic pressure had greater benefits than the standard of less than 140. We had 2 recruitment sites in Louisiana, and I was very pleased to be one to lead one of those. This trial recruited nearly 10,000 patients nationwide to answer this very important question. What we saw over the course of the trial is that lower blood pressure was achievable and sustainable over time, showing that on average, the intensive treatment group had 121 millimeters of mercury, with the standard treatment group around 135. What we saw at the result of this, and this trial was ended early for benefit, those in the intensive group had lower cardiovascular disease by 25%, lower overall deaths by 27%, and lower the risk of combined mild cognitive impairment and dementia. What the question that emerged from this is, does and can this hypertension management strategy and the clinical benefits be replicated in the general community, specifically in low-income individuals receiving care through federally qualified health centers? And the reason this is important is because what we actually see in high blood pressure control is much lower than what we would expect with all of the effective treatments that we have available to us today. Research is urgently needed to address these gaps, which we think are driven by provider clinical and preventive practice guideline adherence, as well as patient adherence to medication. And these, just like evaluation of medications, these strategies also need to be studied in rigorous clinical studies. One such is here, funded by the National Heart, Lung, and Blood Institute in Louisiana, which is looking at the implementation of multifaceted patient-centered treatment strategies for intensive blood pressure control to see if we can mimic these results in federally qualified health centers in Louisiana and Mississippi. What you see here is the broad integration and partnership with federally qualified health centers across these two states, where we've enrolled over 1,000 patients and are actively following them for their blood pressure control as well as their cognitive outcomes. Recruitment through these partnerships and working together on these rigorous clinical assessments have proven fruitful and successful, and that we've achieved 96% of our recruitment goals for the blood pressure study and are a third of the way on our cognitive study. What we've learned and the key takeaways is that this community engaged research with partnerships are key to disseminating evidence-based practices, and that we must understand these challenges in the real world around the need for provider staff training and support on evidence-based guidelines, understanding the barriers, the impact of COVID-19, staff turnover, and with the role of patient adherence. More to come as a result of this study unfold. As we look at this compounding effect of not only high rates of hypertension, but if you look at a similar heat map for rates of non-adherence in older adults, you will notice the Deep South is still beaming with not only high rates of hypertension, but also high rates of non-adherence to medications, creating additional challenges for healthy communities in these areas. The National Council on Patient Information and Education labeled low adherence as America's other drug problem. The World Health Organization notes that lack of adherence to antihypertensive drugs is the most important cause of failure to achieve blood pressure control. And all in all, patient 9 adherence is a $300 billion problem in this country and beyond. What we've learned from our research in Louisiana and beyond is that very little of the variation in how people take their medications is explained by these traditional factors that we think would be associated with medication taking behavior, like social or healthcare system factors. What this has made us do is go beyond and out of our comfort zones to look at other factors that may be at play, such as patients' implicit or subconscious attitudes about their medications, their preference for immediate versus delayed gratification, and the structural social determinants of health. We published recently an expanded adherence conceptual model that includes this broader array of how we need to look and assess and evaluate and hopefully intervene with respect to patient adherence to help people get better blood pressure control and ultimately reap the benefits of that control. We were funded recently again by NIH, Heart, Lung, and Blood Institute, to test an innovative health coaching strategy called STAR-MAP that's actually targeting subconscious and conscious attitudes that patients have toward their medications, and looking at the effect of this not only on their pharmacy fill, but also on their self-report adherence to medications. We're partnering with Blue Cross Blue Shield of Louisiana, the largest health insurer, to recruit patients across the spectrum of diversity, men and women, Black, white, and Hispanics living in urban and rural areas of Louisiana, to not only support our recruitment activities, but also the assessment of the health coaching intervention that we are testing. We're using a most rigorous method of assessing effectiveness using a randomized controlled trial, and we'll follow the patients over 2 years to see whether or not the benefits are sustainable over time. So our takeaways here is that these ongoing clinical and public health challenges and the fact that we've only had modest success in improving these challenges, and that we need an urgent approach for innovative strategies for primary and secondary prevention for uncontrolled hypertension. And this innovative coaching technique we have here, we hypothesize will help patients overcome these challenges, meeting them where they are and leaving them able to reap the benefits. Now, it's also important to know that Although we've known that hypertension has been an ongoing challenge for decades, the COVID-19 pandemic shed additional light and additional stress with respect to this disease and its confounding effects with COVID-19. What you see in Louisiana alone, which was identified early on in the pandemic, is that hypertension specifically, but other cardiometabolic diseases were the leading underlying health conditions in Louisiana residents who died from COVID-19, signaling the importance of the need to target hypertension and hypertension control if we're to build health resilience in our communities. These combinations created a perfect storm, if you will, in Louisiana, having us labeled as a hotspot area early on in the pandemic, and faced with addressing widening health disparities that were identified in our state. We had the wonderful opportunity when NIH reached out to funded investigators in Louisiana to apply for the Community Engagement Alliance Against COVID-19 Disparities grant. Again, focused on eliminating and addressing any health inequities that had been identified, as we saw, across racial groups, in the elderly, in Blacks, in Hispanics, as well as in the American Indian population. There were two goals that were set out in the initial phase: to urgently engage their community, to address widespread misinformation, and to promote evidence-based response, as well as to promote and facilitate inclusion of diverse racial and ethnic populations in COVID trials, as well as in COVID studies. Tulane partnered with Xavier University to lead this initiative. We were one of the first 11 SEAL teams funded. 10 more have been funded. And we used our established partners with community pharmacies, federally qualified health centers, faith-based organizations, multiple groups throughout Louisiana, communications groups, academic institutions, United Home of Nations, as well as ongoing centers that are focused on health disparities and eliminating those disparities in Louisiana. Again, initially, we focused on the hotspot areas, evaluating and assessing in New Orleans, Jefferson, and Baton Rouge. But as the pandemic pulled forward, we realized that in our rural areas in North Louisiana, there were also disparities that we had to address. So we expanded to include those groups. We launched a massive Halt COVID Louisiana communications campaign, with Xavier taking the lead on this, realizing it will take all of us if we want to combat COVID-19. We collected data with our community partners. They helped us in that data collection, and we provided very simple summary data statistics back to them about key motivations to and not to vaccinate, and who the trusted sources of information. We wanted them to be able to use this information in real time to help address the challenges they were experiencing in their communities, so that we could help our communities respond to this pandemic and ensure the safety and wellness of our groups. We participated in a number of conferences, including one like this, the Empowerment and Policy Conference, allowing the Louisiana SEAL to present our community, our health, and our response to COVID-19. Hot off the press and received from the Louisiana Department of Health just yesterday, our efforts, but together with efforts across Louisiana, funded by multiple groups, we have seen not only an increase in vaccination rates over this past year, but we've also seen a reduction and elimination of the disparities in vaccinations between white versus Black individuals living in our communities. Again, it takes all of us, and we were proud to be part of some of the research that led to some of these positive changes. Our takeaways, again, that community engaged research and listening, engaging, and meeting people where they are is critical if we're going to disseminate evidence-based preventive measures and expect them to be uptaken. Inclusive participation is key, as our communities have asked for the evidence that what works and what doesn't work is reflected in all who could benefit or could be harmed by treatments and interventions. Overall, LaSalle shares in the success in improving Louisiana vaccination rates and reducing the disparities caused by this pandemic. But as we move from COVID crisis to COVID control, there is an urgent need for us now to integrate clinical preventive services like blood pressure management, routine vaccinations, and cancer screenings with our COVID-19 related services. And my last summary is to highlight the role that preventive medicine physicians are playing in preparing this next generation of physician and academic leaders. We're doing this through our preventive medicine residency programs that are funded by HRSA, but also, I lead several grants funded by NIH that train pre-doctoral students, residents in medicine and pediatrics as future physician scientists, as well as through K-12 programs, training early faculty for scientific careers. Again, very important that we be part of a workforce development that's going to lead our country and our area stronger. So in summary, preventive medicine physicians are engaged in academic medicine. We're well-trained, board-certified doctors practicing at the interface of medicine and public health. We are leading major research initiatives designed to improve health and wellness in communities and ensure health equity in the U.S. and beyond. And we are ensuring a robust pipeline for tomorrow by training the next generation of preventive medicine as scientific and academic leaders.
Great. Thank you so much, Dr. Krause, for your riveting talk, and of course, all the great work that you're doing in Louisiana. The health of populations in rural settings can be extremely challenging due to the social determinants of health. And I think you've demonstrated how preventive medicine physicians continue to make an impact in population health and the importance of partnering with organizations, health systems, academic institutions, and of course, the community. So thank you so very much. We've got claps from the audience. We also had some questions queued up for you, and I think we were going to open up and just see if there's any hands raised, Drew, to see if anybody wants in gallery form to ask any questions. So while Drew's doing that, why don't I ask a first question on how can preventive medicine physicians be positioned to help address the burgeoning issues that we see at the community level with their health and health care and into the future?
Well, there's several ways that our preventive medicine physicians are essentially on the front lines. Some are actually engaged in the clinical care of individuals, delivering primary care, ensuring that preventive services are being delivered, not only for COVID-19, but also for the other underlying health conditions that plague our communities, correct? But we also have many of our physicians at the forefront in departments of health that are working to outline and support the strategies that reach out into the communities, setting up infrastructure and support to address not only the pandemic, help with contact tracing, but also to ensure that the right structures are in place for managing these underlying health conditions. And of course, the research that is important that shows us what works and what doesn't work in community engagement, as well as in implementation of guidelines and practices, are going to be key. So across all those angles, our preventive medicine doctors are working in those areas.
Thank you. And one more question while people are gathering their thoughts. Please feel free to raise your hand, post your question into the chat. How has the pandemic impacted the ability for populations to adhere to the U.S. Preventive Services Task Force's recommendations for clinical preventive services?
A great question, and it's the concern we all have and the tsunami that we think is on the horizon. As we have been hyper-focused on COVID-19, there has already been published evidence that there have been hundreds of thousands of primary care visits that have been missed, screenings that have not been conducted, mammograms that have not been done, and people who are going forward without having their blood pressure and their diabetes checked. So there may not be an immediate effect within weeks or months, but what we know from the scientific evidence is that over time, these conditions left unchecked lead to more severe disease if they're detected later, complicating treatment and increasing cost, not just in dollars, but in time and in quality of life to individuals that will acquire these diseases. So one of the things we heard back from our community partners was the incredible need to integrate these services. And by doing so, not only will we do better for our communities and the patients we serve, but we will likely help decrease some of the burnout that our healthcare providers are experiencing as they have been this rapid turnaround dealing with COVID-19, but still seeing unchecked primary care needs of their patients and their communities.
Great, thank you. We have a couple of questions that have come in from the audience. First, have you found that hypertension medications work equally for people of various races and ethnicities?
Yes, the randomized trials have provided very clear evidence that they work across men, women, and across racial and ethnic groups. And that's wonderful because what it means is that we do have things that work and are well tolerated and reduce blood pressure across the spectrum of people who get hypertension.
Excellent. And another question that came in, what evidence exists regarding the success of involving the family in hypertension control when you're addressing the individual patient? Can you talk about the family dynamics?
Oh, I think that's a great question. You know, none of us live in a silo or on an island. We live with people, family, and friends that can support or perhaps even not support what we're doing with respect to our health. So for many patients, we have found that and as we're going to be testing in our novel health coaching activity is where engagement of family members or other support, a positive support, may be effective in helping individuals manage their high blood pressure and ensure that they're addressing the current concerns and challenge they have in meeting their blood pressure medication adherence goals. Excellent.
Thank you so very much. Well, it looks like that concludes our questions for this specific topic. And so thank you, Dr. Krause, for all of your great work and all of your leadership and all of the academic excellence that you continue to advocate for. And really thank you. And so for the audience, please feel free to know that we'll take additional questions and we'll be happy to follow up with them. If you have any questions for Dr. Krause, you can certainly email us at ACPM. There will be a slide at the end of the show on where you can contact us. So thank you so very much.
Thank you.
So now we're going to move to the next speaker for today's session, Dr. Chris Purnell, and the important topic of health equity in the distribution of COVID-19 vaccines and the impact of disparities in the midst of this pandemic. Dr. Chris Purnell is a nationally recognized physician leader and social change agent, and hopefully you have seen her on the numerous interviews on MSNBC and CNN. In her public health practice, she focuses on health justice, community-based advocacy, and health promotion and disease prevention. Working as the Chief Strategic Integration and Health Equity Officer at University Hospital in Newark, New Jersey, she oversees a portfolio that includes population health, strategic planning, community affairs, and the human experience. Of note, her role was created to lead the hospital's first health equity and inclusion strategy in an integrated fashion across multiple business units. We've also been fortunate to have Dr. Purnell serve as our Chief National Ambassador for the ACPM Vaccine Confident campaign, highlighting the safety, efficacy, and science of vaccines, both for COVID-19 and other diseases. Dr. Chris Purnell, please take it away.
Thank you so much, Donna, and good afternoon, everyone. It's quite a pleasure to be before you to talk about what I have frequently said and described as heart work. This is truly a passion for me: health equity, health justice, racial justice. And what we've seen in this particular unprecedented crisis that we're going through as a nation, as families and as community is a collision course of several pandemics. And so I will start out by describing what is the status quo and what are the realities that we face. And I'll say more about that collision course of multiple pandemics. Some have said twin pandemics, others have said they're triple pandemics. And so if you could advance to the next slide. So often we hear talk about equity, we hear talk about equality, and we hear talk about justice. And I came across this graphic. There are several popular graphics that are circulating that are frequently seen and used in many of the talks and the national dialogue around health equity, which has rightly taken up its place at the center of the table, given the disproportionate impact that the pandemic has caused on Black and Brown and Indigenous and Native communities, and the summer of upheaval of 2020 around the public murder of George Floyd and other brutalities experienced by Black and Brown persons. So this graphic here, created by Tony Roof, I hope really crystallizes for you the context of the work that I will describe that is happening here specifically at University Hospital, and the work that is happening across the nation and should happen across the nation. So here you see a tree. This tree is obviously leaning to one side. On the left side, from my vantage point of this tree, you see multiple fruit. You see that the person who's on the left side has a fruit, either it's falling just naturally by gravity from the tree, and the person off to the right, you can only see a portion of the tree, but there isn't as much fruit, and there isn't as much access to the fruit that is there. So inequality, if you will, is unequal access to opportunities. I so often have this conversation and people say, isn't it equality that we're striving for? And actually, no, it's not. And this graphic is a great representation of that. It is more than equality that we're striving for. Because if you give people equal resources, or you give people or groups or communities equal tools and assistance, it doesn't take away the fact that the tree is bent or skewed in one direction. It doesn't lessen the fact that there are multiple pieces of fruit on one side of the tree and less fruit on the other. For those of you who are in the field, perhaps you're beginning to think of Dr. Kimmerer Jones's gardener's tale, and you're thinking about just how important the soil is, and you're thinking about the different colored flowers and how it appears that flowers of a certain color are richer, more vibrant, season after season, that they replenish, that they grow, and that flowers of another color don't seem to do as well as the others. And so you just throw in some new soil, but even when you throw in the new soil, it still doesn't remove the historical context, so historical truths and realities that are there. That tree is still skewed. So next we talk about equity, and it's really important, and I have this conversation literally every day. It is really important that we in preventive medicine and more broadly across the nation and in this dialogue, that we solidify the understanding that equity is rooted in need. The need that is demonstrated and characterized across groups, whether those are needs by race and ethnicity, whether those are needs by sex, gender or gender identity or gender expression, whether those are needs characterized by sexual orientation, religion, the various and the host of ways that people are characterized, there are needs. And so equity says there are custom tools, right, that identify and address the inequality. Again, I go back to Dr. Kimmerer Jones's work, and she says, if we do not explicitly ask, how is racism operating here, then we cannot intentionally solve for anti-racism. So you see ladders of different heights, right? You see the person on the right side of the tree now has a substantially higher ladder, but that substantially higher ladder allows the person on the right to do the same thing as the person on the left, okay? And now the person on the right can access the fruit in the tree, but still it doesn't change the fact that the tree is skewed and that there is more fruit on the other side. And finally, justice. Justice is making the tree upright. And in making the tree upright, improving the conditions and the systems and the factors that then can contribute to the growth of equal opportunity. So when I say it's not about equality, because it's about more than equality, it's about equity, customizing tools and resources based on identified inequalities or need, and justice is about fixing the system. So I began to say that this has been a collision course of multiple pandemics. I frequently talk about the collision of the pandemic of systemic racism and the pandemic of coronavirus. We know now, going greater than 2 years into this pandemic, that Black and Brown communities were disproportionately devastated. There have been earthquakes of devastation in Black and Brown communities. All Americans, all persons across the globe have been touched by this unprecedented crisis. But disparities have emerged that do not allow us to ignore, or do not allow us to neglect, or do not allow us to lessen the obvious anymore. Next slide. And so what we've seen in particular in this pandemic, and it's something that we here at University Hospital have been thinking about. University Hospital has a very storied history in the city of Newark. The city of Newark has a rich history. It is important in practicing medicine that you know the history of the community, that you understand not only the historical factors, but you understand those contemporary conditions, those contemporary truths, those contemporary injustices, if you will, that predispose certain groups to lesser outcomes. And so what the literature is showing and has shown, and what we know from practice and history, is that the collision of systemic racism and coronavirus led to disproportionate outcomes in Black and Brown and Native and Indigenous communities because of various factors. And these are some of those factors that these authors have identified. So the higher burden of recognized comorbidity not effectively treated. For us at University Hospital, the way that we have begun to reflect on that is that we know that during the pandemic, millions of Americans have either delayed care or they have foregone care altogether. We know that they have in particular delayed or they have foregone preventative care. We know that more than 26 million immunization doses were missed during the height of this pandemic. That's not specific to coronavirus. That is across a host of conditions and diseases. Knowing this higher burden of recognized comorbidity not effectively treated at baseline that has been exacerbated during the pandemic, we here at the hospital did a painstaking audit of over 200,000 medical records. And in doing that audit, we were able to query the data and to say who missed critical screenings or critical prevention measures during this specified time across 1 year. We were able to identify roughly 2,700 patients and to begin to design specific communication and outreach strategies to get those persons into appropriate care. Over 65% of University Hospital patients have multiple comorbidities, and we're talking about a prevalence burden of high blood pressure, a high prevalence burden of diabetes, of congestive heart failure, of COPD, of obesity and overweight, and even more broadly in the larger greater Newark area, in the Newark community, the burden of those diseases align itself. Essex County, unfortunately, is one of the sicker counties in New Jersey, and that is where Newark sits. So that was our attempt to think about the higher burden of recognized comorbidity that not only has contributed to worse outcomes in this pandemic, but perpetuates inequities at baseline. And patient distrust, this is very important. to think about, but to tie this into lack of patient expectation that engagement would be meaningful. So we know not only is there identified and recognized comorbidity, but if you just think about pre-diabetes and diabetes, we know that in particular, the same communities that have been saddled with historical injustices have been excluded and stigmatized and have been marginalized. There are higher rates of unrecognized comorbidity. And what is driving that? That is being driven by lack of access to healthcare and lack of patient expectation that the engagement would be meaningful. If you touch a hot stove and it burns you, and you touch a hot stove multiple times, then you train your body to say, I don't touch the hot stove. But what does that look like for a patient? If you come to a health system and you feel as if your symptoms are not heard, your symptoms are ignored or devalued, if you feel like you don't have a connection with the physician, if you're questioning, does this physician value the social and cultural context in which I live, in which I make my medical choices and decisions? Are you a collaborating equal? Are you a partner? Is there shared decision making? If those things are broken, right, at baseline, that actually teaches or encourages a person not to engage in effective health-seeking behaviors. So we know that at baseline was also heightened and exacerbated because people were afraid to come to the hospital. We saw roughly around June, thereabouts of 2020, that we had a significant drop-off in our emergency department of people showing up for strokes and cardiac arrest. And it's not because that people were not having heart attacks or having cardiovascular emergencies. It was because people were not coming to the hospital, because at the same time, we saw a concomitant increase in our EMS calls, a 200% increase, if you will. And finally, increased COVID exposure. Increased COVID exposure is linked to poverty, residential crowding, frontline occupation, and public transportation, as these authors hypothesize. What we know here at University Hospital is that we've done an aggressive equity and inclusion strategy rollout. And as a part of that, we're learning about our cultural competence or our social and cultural fluency as an organization. And we're doing that in a 360 manner. We're not just asking our providers or our staff, but we're asking our patients and their families, and we're asking our community partners and our vendors. And likewise, we've mobilized a social determinants of health screening tool. We did that starting in May 2021. Very small subset of patients that we're looking at in our ED. We have data of roughly about 275 patients or so. We want to know those who are high utilizers of the emergency department and who have several chronic conditions, and what are the needs that they have identified, and how as an anchor system and an anchor institution are we working to fix those needs, because those were exacerbated during the pandemic. The complex web and interplay of all of those issues led to higher COVID mortality in the Black population. At University Hospital, in our first wave, we had over 1,000 patients hospitalized with coronavirus. Those patients were overwhelmingly Black and brown. Approximately 50% were African American, and over a third were Latino or Hispanic. Next slide. So what have been our specific responses and efforts as they relate to the COVID-19 vaccines? I was explaining to you more of our systems approach to understanding how systemic racism has determined, influenced, and shaped certain disparate outcomes during this pandemic, and our response to some of those structural factors or structural determinants, right? But specifically around COVID-19 vaccination, it has necessitated partnership. It has necessitated collaboration. It has necessitated culturally competent collaborations. So knowing assets in community, knowing what community themselves define as assets, right? That level of authenticity, putting forward community messengers, so community health workers, trusted messengers, also assets who can not only vouch for the validity of prevention and therapeutic tools, but who can be a a navigator or a go-between between systems and community to get at some of those broken trust issues, to ensure that access is reflective of community needs, right? So we personally, as part of University Hospital, we've administered over 55,000 COVID-19 vaccine doses at our last count just at the end of the year. And that was achieved primarily through our on-site vaccination clinic. We developed and launched a vaccination clinic that was open for 6 out of 7 days a week from 7 to 7, depending on where we were in the pandemic and the surge. We would elongate those hours. Right now, we're currently using a model where we dedicate certain days to pediatric persons, and we invite families to bring their children in so they can be vaccinated. And a significant portion of that on-site vaccination clinic has been around making sure we're partnering with the community-based, community participatory. So we know what the city's efforts are, we know what the county's efforts are, we know what community stakeholder groups are doing, and saying, in addition to our COVID-19 vaccine clinic, how can we plug the gaps in the resources? So with those collective efforts, we have fully vaccinated, as according to today's definition, more than 25,000 of our regional neighbors. And that's also using our EMS units to staff or to support city-run vaccination sites and things of that nature, or helping to ensure that frontline workers or critical infrastructure workers are getting vaccinated at their places of employment. And finally, we partnered with the New Jersey Department of Health to get vaccines deep into community. Pre-pandemic, we were talking about healthcare 3.0, public health 3.0. We were talking about the need for community integrated care models, right? Coming out of this brick and mortar institutionalized approach to healthcare and going deep into community. Again, using community health workers married with a mobile van fleet. The New Jersey Department of Health and University Hospital have partnered to dispatch those vans to communities that have been disproportionately impacted and are known to have low vaccination rates, right? So as of the end of this past week, the vans have provided more than 7,600 shots in 23 towns across 156 days. And that has been a multi-layered strategy with using the community health workers, using a medical team that is attached to the van, and also using texting, right? Using texting in a specific geographic region to say, hey, vaccines are available. So door knocking, texting, and bringing the vaccines as close to people where they are, ensuring that people have the access that they need. They are being served by people who reflect the social and cultural fluency of the community. And so we've seen that level of success with those type of collaborative and partnership efforts. So thank you for this opportunity to share a little bit of the work that we're doing here at University Hospital, and to talk more broadly around the need to center all strategies with an equity infused and an equity-driven approach, and ultimately how equity behooves that we focus on a justice initiative. Thank you.
Well, thank you, Dr. Purnell, for your passion and inspiration, and of course, your leadership at this very critical time of our nation's health to ensure that populations that have been marginalized have the information, access, and care that they need to realize good health. And hearing you speak, all I can think of is, wow, wouldn't it be amazing if every single hospital had a preventive medicine physician, such as yourself, that could truly analyze the population health data in their community to truly look at the right strategic preventive medicine interventions that need to happen in their community. I think we would be light years ahead of where we are today.
Yes. In fact, yes.
So while people are, please raise your hand, ask questions, put them in the chat. I have a couple of questions queued up for you already, sure, if you don't mind. So the COVID-19, as you've already indicated on a number of points in your talk, raised numerous examples of the inadequate access, care, trust, and the ability to ensure that populations receive vaccines in a timely manner. What specific role do you feel population medicine or preventive medicine physicians could serve in addressing access and health equity at the community level in their own backyards?
Definitely. I think the models that I've just described are so illustrative of that, right? We have had frequent conversations around the table that if we build it, they will come. And that's not true. That is not a community-centric approach. That is not a people-centric approach, right? So understanding what drives or motivates health-seeking behaviors and understanding the structural, political, and social factors and determinants at play on the ground that actually become cues or triggers in the environment that influence decision architecture, right? And so having that level of awareness. So at baseline, prior to the pandemic, and especially, occupying this role, with a population health perspective, with a systems thinking perspective, we wanted to get deeper in our understanding of data and saying, what do we know about this community? And to what level of granularity do we know it? Do we have zip code level data? Do we have ward level data? So that's specific to Newark. The city is separated or characterized by wards. Do we have ward specific data? Do we have asset mapping? Are we aware of resources that are already on the ground? Too often systems have an approach and systems design absent of community participation, absent of community expertise and insight, exactly the types of resources that will match the identified needs. So here is where asset mapping comes into play. As a preventive medicine physician, we are trained to think in systems. We are trained to think about how do you know the truth, right? What is the data supporting that? How did you get that data? And so did the data reflect a community participatory approach? So we've married that type of understanding and strategy to our health equity focus here at the hospital. And that's something that preventive medicine physicians and population health physicians afford, that type of thinking, right? And so that led us to say, we don't have to do it all ourselves. We can partner with other assets in community to ensure that needs are being reached as deep as they exist, and that we also had to think about what would cause people to want to come to the hospital. Even when people were afraid, Donna, to come to the hospital, we did an aggressive social marketing campaign, care around the clock, right? And we helped people to understand that it was safe to return to the hospital, the type of care that they could receive in the hospital. We laid the data bare, right? Data transparency, what was happening. Our strokes and cardiovascular emergencies were falling precipitously. And we knew that people were still dying in the field because our EMS runs were showing it. That's what a preventive medicine approach affords and what has been necessitated throughout this pandemic. That is the only way that we're going to be able to treat populations in a more holistic fashion and ever achieve health equity.
Excellent. Another question. I think you give everybody goosebumps just hearing the passion in your voice. So thank you for that. Preventive medicine physicians conduct their rotations in health departments, as you know, and as an experienced yourself, across the country. And 2/3 of all of our applicants that come into residency programs are non-white. So what would you suggest? What needs to really happen to ensure that we have adequate supply of trained preventive medicine physicians at the community level that truly reflect or represent the communities in which they serve?
Right. So let's talk really briefly around pipeline. So I was a little Black girl in East Orange, New Jersey, when I first dreamed up this dream of becoming a physician, right? And so we have to continue to amplify the voice of preventive medicine and preventive medicine physicians. And we have to do it in a way that is creative, innovative, and reflective of the diversity and the eclectic nature of thinkers and doers that we are. But more importantly, we have to ensure that our residencies or training opportunities are fully funded, right? Because preventive medicine physicians operate at various levels of healthcare. Preventive medicine physicians like myself, I'm working in a healthcare institution. I'm working in the state's only public academic health center, okay? So not only are we a level 1 trauma center, but we have innovative programs around hospital-based violence intervention, and that rests in my department, and a preventive medicine physician looking through a population health lens. We can't make those things happen without funding of training opportunities, full and robust funding of training opportunities to show I've had people ask me, well, so what makes you different from someone else who is a practicing physician or practicing provider and says, oh, I want to learn more about population health or public health. I say, we're a group of physicians who are expertly trained in the integration of clinical medicine and public health. So even if you're not in the local health department or not at the state or even at the federal level, you have a person who has the skill set to think across successive levels of population, whether it's clinical populations, whether it's race and ethnicity that populations are defined by, whether it's a geographic population, and think about those factors that are contributing to a pattern or distribution of outcomes, and then say, what do we need to do differently to optimize health and well-being? That's what we need everyone to understand, because when that is better understood, the funding priority has its right place.
Are there any additional hands raised or anybody who wants to ask a question? So what about mental health, opioid addiction, and what we've also seen? Can you discuss a bit about the inequities and the role that preventive medicine physicians play in addressing those areas of need?
So I want to talk about two populations in particular, because those are novel programs that we're doing here at University Hospital. Like others in healthcare, we have seen a surge on our crisis ED, right? We see whether we're talking about juveniles and those across school age presenting with suicidal ideation, or people presenting with symptoms of mood disorders, that has been at a staggering increase, right? And it gets at this issue of, unfortunately, a lack of appropriate community-based resources for people to have appropriate mental health and behavioral health care provided in a culturally fluent fashion, okay? And so that is something that we're currently thinking through with our partners at the state, with our partners across the county. What we saw when it comes to mental health and behavioral health care, that rightfully so, there's a push around deinstitutionalization, but there haven't been, I would say, robust enough community resources. And actually, what we're seeing in one community in particular, and we do work with this community, are those who are currently incarcerated or those who are re-entering society. We have a subset of women that we have been working with. There is a project here in the state of New Jersey looking specifically around re-entry issues for women. And you can imagine women who have been disproportionately impacted in this pandemic. We've heard people talk about a she-cession, right? Black and brown women in particular who have been impacted by this pandemic, who are all also represented at higher levels in our systems of incarceration, and then re-entering society during a pandemic, and thinking about the mental and behavioral health conditions that have been exacerbated because of that. So we've started these very dynamic models where we use group, it's not group treatment, but group opportunities for women to learn about health conditions, to learn how to navigate health systems, to learn how to process the emotions that they're going through. And we're doing that with those in the correction field, with those in the re-entry field. And that is something that has really come to a head during this pandemic. So we're thinking about it in multiple ways. The more, let's say, expansive way of available community-based resources because of deinstitutionalization, and then that more granular way where actually deinstitutionalization has actually seen an uptick in our incarcerated population and an uptick in those re-entering society being saddled with an exacerbation of mental and behavioral health issues.
Wow, this is amazing. So you preventive medicine physicians clearly have a very broad perspective and deep expertise. So again, thank you so much for your authentic leadership. You're a breath of fresh air, and I'm certainly will see you on MSNBC in the not too distant future. So thank you so much, Dr. Purnell. And again, if there's other questions, we'll certainly bring them forward to you. So
thank you.
Thank you. So now we're going to move and turn to technology and hear from Dr. Linda Ferry on innovative solutions to using telehealth and technology to address chronic conditions and to serve veterans in meaningful ways to ensure the proper care and treatment. So, Dr. Ferry, I've had the distinct honor of knowing and working with Dr. Linda Ferry for the past few years on an innovative and cutting-edge program in delivering care through a virtual medical care system. Dr. Linda Ferry is an associate professor for preventive medicine and family medicine at the Loma Linda School of Medicine. She has been the principal investigator on a number of federally supported research programs focusing on tobacco cessation and prevention across diverse populations and practice areas. She's currently the Joint Incentive Fund Independent Project Director on cardiovascular disease reduction for the Veterans Health Administration, leading research into the use of innovative technologies to improve access to care for veterans. She wears many, many hats, as you see here, and has just been a remarkable leader and a very passionate preventive medicine physician. So thank you, Dr. Ferry, for sharing your talk and spending your time with us today.
Thank you very much. And it's a delight to present with both Tinnette and Chris today. You're seeing in these three careers, physicians who have taken this population health, public health, and clinical preventive medicine into communities, into hospitals, into clinical research programs, trying to understand how to make healthcare better. Donna has already told you that preventive medicine is one of the oldest specialties, organized in 1954, but public health doctors working in state and public health departments were organized even before then. But the thing that makes preventive medicine residents different is two things. Number one, preventive medicine physicians, before they take their board certification, have to complete a master in public health. That's not true of any other physician. That's why you heard these presentations from Tinnette and from Chris, because they have epidemiology and biostatistics and health behavior change bred into them as part of the projects and training that they did during their MPH and residency programs. And that is not true for our other colleagues in all other specialties. The second thing that is unique is that preventive medicine residencies don't get funding like other training programs. And that means that we have to go out searching for someone who wants to help pay for someone to be trained. One of those sources is the Health Services Research Administration, a HRSA grant, which when I was program director, I was fortunate enough to get. I would like to tell you the sequence of where my preventive medicine training brought me, and then make an opportunity for you to learn more about this very interesting VA virtual medical center that we're working on right now. The background that I have is as a graduate from Loma Linda University School of Medicine. If you know anything about Loma Linda, about an hour east of Los Angeles in Southern California, Loma Linda School of Medicine opened in 1904, 1905. It's the only medical school campus that has been tobacco-free since it opened. There's no other medical school campus that can be said for anywhere on the planet. And that's just the taste of why preventive medicine is so natural at Loma Linda University. In fact, people who are neurosurgeons and ophthalmologists and radiologists, they think they understand prevention, and they're preventive oncologists because our training is so steeped in healthy lifestyles and prevention. So I started from that in the 70s. In the 80s, I completed my family practice training at the University of Texas, San Antonio, and then came back from Texas to California because Texas didn't quite understand prevention the way I was looking for it. And I completed my preventive medicine training back in Loma Linda while working in academic family medicine. 37 years ago, I began my career at the VA hospital in Loma Linda, California. At that time, there was an opportunity to work in addiction medicine, which greatly shaped what you're going to hear me talk about today as to the activities of my career and what I'm involved in. I became, 3 years later, the program director of the preventive medicine residency at Loma Linda, and was gratefully funded by the HRSA funding mechanism for a 10-year period. We retained those grants. That allowed us to reach out into the community and get funding from the health department, from Kaiser, from a Medicaid sponsored agent in the community, from a state mental health hospital, from the VA hospital. We started with 2 funded residents and went to 5 during the course of the time I was program director. And that then set the stage for a VA hospital, which you haven't heard about yet, being the place where preventive medicine residents address population health and preventive medicine. So my start 34 years ago as the academic leader for preventive medicine then brought me through the HRSA funding to develop a database for our very high-risk population in the VA of women veterans. You may not have worked with or thought much about the veteran population, but women veterans are a very special and unique high-risk population because of the experience they've been through for 1 to 4 or 10 years, operating in an environment where they're the minority, they're the sexual minority, and they have a lot of inequity in their healthcare and in their treatment as high-risk, vulnerable populations in a predominantly male culture. I became the director of women's health, and we designed, using our HRSA money, a database before we ever had an electronic health record at the VA. That didn't start till the year 2000. So in the 1980s and 1990s, we started a 4th dimensional database on high-risk women veterans, trying to understand their needs, their experiences that they've had, their mental health issues. And we developed a tracking database for tobacco because we had started a tobacco treatment program. Now, the tobacco treatment program at our VA was the first at that hospital. They never had a tobacco treatment program until a preventive medicine physician showed up, because tobacco isn't really owned by any certain specialty. No one holds that as their own area. Everyone kind of ignored it. So if you would start with my slides, I'd like to tell you how this, next slide, how this happened. So, oh, sorry, back 1 slide. There you go, you're at the right one. So after being the program director and getting HRSA funding and developing those databases, we finally did get an electronic health record. And we became a hospital-based, at the VA hospital, preventive medicine residency. Even to this day, there are very few preventive medicine residency programs funded at and working at VAs, which is a tragedy. Every VA hospital should have someone like Chris or someone like Tinnette or me working at that hospital, working with their very high-risk veteran population. One of the things it allowed me to do was to design research projects on veterans, and using my idea that bupropion, then called Wellbutrin, an antidepressant, might be helpful in improving the withdrawal symptoms of tobacco dependence. So as a resident project, we conducted a trial from 1991 to 1994, and within 3 years had enough evidence with a wide-reaching research protocol at multiple other centers to verify our findings that bupropion became the first FDA-approved non-nicotine treatment. Everyone was looking at nicotine gum and patch at the time that we started using bupropion. There's only been one other non-nicotine medicine approved since then, since 1997, and that's varenicline or Chantix. That experience was really exciting and really increased the number of veterans who wanted to come in and get treatment. And over the course of those 33 years, we've treated over 18,000 veterans, more than almost any other VA proportionately, because of that enthusiasm of someone owning the tobacco treatment program and aggressively recruiting patients. After that experience, I had the opportunity to take my tobacco research experience into the international environment, and NIH Fogarty International Center gave an opportunity to do tobacco control leadership in developing countries where they did not have adequate tobacco control laws. That was a very exciting experience from 2000 to 2007. And we took physicians from the Ministry of Health in Cambodia and Laos. We brought them to Phnom Penh. We trained them in a certificate program for 15 units from our School of Public Health to give them all the skills they needed to do tobacco control and do research. And we were able to mentor them, help them start research projects in their own country, and have maintained relationships with them since then as a public health aspect of part of my career, in which our residency program also got to have benefits. Then the next leap occurred, if you see on the right, these are expertise areas that within my hospital-based and academic career I've been working on. Tobacco treatment program has in blue because it's predominantly where most of my experiences outside the VA have come from. And the last one I'd like to tell you about is how we are exploring access to telemedicine to our veterans and active duty service members for prevention of cardiac disease. Next slide. What you see in this picture is the virtual medical center lobby. So this is a platform where you enroll, you make yourself an avatar that looks any way you want, including active duty military uniform, and you participate in your care through your avatar to avatar interactions. The idea is that this is going to become a virtual healthcare campus that you participate in from home. It is now available to veterans and active duty service members in the DoD 24/7, as long as you have a computer that you can, laptop or desktop computer, you'll have full access to it. If you have only an iPad or a phone, you'll be able to use it in the 2 dimensions and not the 3 dimensions of actually exploring and walking this facility. The experience of working in a virtual world has our patients saying they feel it's real. They don't feel like they're playing a game because they're interacting, they're raising their hand, they're pointing, they're gesturing about how they feel about what you're talking about. And that kinesthetic experience makes you feel like you have just seen a doctor or been in a group that happened in real time, was a real experience in person. We this year just got a web-based version. We're very excited about that. We're working out the kinks, so you no longer have to download software on the desktop. Next slide. This is the history of the Virtual Medical Center. If you've never heard it, it was originally developed in the Department of Defense and sent to Big Brother VA in 2015. The early initiatives on the right show you what topics have been tested and proven to be effective since 2016. You can see again in blue, I was able to get an innovation award from the VA that allowed me to develop tobacco support groups. So one of my support groups that met every week was meeting in the Virtual Medical Center for people who needed to stay home or didn't want to come to a face-to-face group and had enough technology knowledge to participate from a computer at home. Of course, during the pandemic, we can give quality care for tobacco dependents safely at home. Our veterans are very high risk in tobacco, having smoked often for 20, 30, 40, 50 years before we catch them and are able to give them treatment. In the Virtual Medical Center, there is both provider-facing information and patient-facing information that can be utilized for training of staff, not just for patient care. And the goal was to create the offerings in the Virtual Medical Center to supplement or meet unmet educational and clinical needs, in addition to the care they were receiving from their own healthcare providers. Next slide. So I'm going to tell you now about our project. The Joint Incentive Fund requires the DoD and the VA to partner together on a project that benefits them both and provides equal services to active duty service members and veterans. So we had an opportunity to fund this for diabetes self-management within the DoD and VA. That project is wrapping up this year in 2022. and certified diabetes educators were trained how to use the virtual medical center so their patients could stay home, not have to come in. And this was planned long before we knew about COVID. So we had this in place, and then, wow, a year later, COVID struck the scene. And we found, hey, we're in a perfect position to continue all of the things that we're doing here, because no one needs to not be able to get our services. They can do it from home. My project allowed me to develop a performance, health, and wellness center. It's just been released in the last month to be able to embed learning media education. It's not available for public viewing yet, but it'll happen in the very near weeks to months. And patients can go in for professionally led groups to use the education in the center, or to do self-directed. Why not just do your own? Walk in and we'll give you a guide, and you can learn as much as you want to at any pace that you want to. And our project is to compare that to face-to-face standards of care. Next slide. I'm going to let you see our DoD partner. Donald Schell is a physician who's in charge of disease prevention and disease management in the Department of Defense. And he's our key partner of having this be spread and understood in the DoD community, which is quite a challenge, and to recruit active duty service members to participate in our pilot studies. Next slide. Here you get to see the preview of our Performance Health and Wellness Center. The little avatar you see on the right is actually what we call an information avatar. When you get close enough to her in proximity with your avatar, a little circle appears above her head with the letter I in it, meaning she's an information avatar, and you can click on that and see all the frequently asked questions. And then she indicates that you're to go to the left over to the upright kiosk that you see with the VA logo on the bottom. And that gives you your welcome information and directs you into the center atrium. In the center atrium, you learn about stroke, peripheral vascular disease, and cardiac disease, and how risk factors put people at risk, and how to determine your own individual risks. From the center area, where people congregate and talk, in addition to participating in the educational offerings on the screens there, then as you can see, there are rooms around the periphery in this hub and spoke arrangement. We actually have 14 rooms. Each room is dedicated to one or two risk factors for heart disease, including genetics and sleep and gender differences, and how to talk to your doctor about getting the care you need, getting screenings that you need for vascular disease. So over the next year, we have another year plus to finish our project. We'll be doing pilots in this group. We have preventive medicine residents that we've hired in other VAs, preventive medicine residents and faculty who are participating in this whole pilot development. And when we're done, it will be available for anyone to walk in on their own and say, okay, what is this #1 killer of active duty service members and veterans? Why is this #1? What can I do about it in my own life? Next slide. So if you're interested, go back one. Yeah, if you're interested in learning more about the Virtual Medical Center, I encourage you to jot down the letters in red at the bottom of this screen. Our address is www.vavmc.com. And when you see that screen, you'll see something like this with the little white arrow to watch a video. You'll get a 4 to 5 minute video that will give you a tour through all the building, and it will include the beautiful Heroes Beach with a beautiful sunset, campfires, verandas, little cabanas where veterans love to go, and my tobacco support group loves to have their meetings around the campfires on Heroes Beach. I am now open for questions, and thank you so much for looking at what we're trying to do with telemedicine, improving access to care for people in rural settings, people with social inequities, people who don't want to come in face to face. They can still get quality care through our program. And you can contact Donna Grande, because we created a grand rounds about the front cutting edge of telemedicine that she can direct you to, an hour and a half coverage on that topic. And we're now working on what to do about the health inequities, social inequities, and financial inequities for those who don't have the ability to use telemedicine. The VA actually is doing some things about that. We are working toward getting telemedicine access to our veterans on a one-on-one basis if they really don't have access in rural locations. So that's a different topic. So thank you very much for your attention, and those of you who stayed around to the last presentation.
Linda, thank you so very much. Dr. Ferry, you inspire, your passion, your leadership, and thank you for sharing your incredible journey, your career journey with us, and all the work you do to serve the veteran population of America. It's just really laudable work, and it's such important work on top of it. We have a couple of prepared questions, and then I know there's going to be a couple of questions coming through in the transom as well. So during the pandemic, access to care has been a challenging experience, especially for routine doctor visits and regularly scheduled screenings. How can technology address and mitigate or enhance the ability for patients to receive the care they need?
So I'll give a quick example of what happened to me. I run 5 groups every week just for tobacco with my nurses and psychologists, and all of these groups were face-to-face except for one, my virtual tobacco support group. The week that the pandemic hit in March of 2020, we suddenly couldn't run groups. And so we scrambled to create a telephone group, to get everyone the phone number to call. I mean, it was a chaotic 2 weeks before we got reorganized. And I had one group, my most successful group in my whole career, where I had between 20 and 30 veterans coming in face-to-face every week who were very high risk for relapse to tobacco dependence, coming into a tobacco support group with our health psychologist. That dropped from 20 to 30 members participating every week to 5 to 12. We tried to get them up on a video group. We could never get them to do that because most of these tobacco dependent, very high risk mental health addiction veterans just don't have the technology knowledge. They're older and they don't feel comfortable using technology for care. So we've only been able to maintain that by phone. My second group with my women veterans, we had up to 12 women coming every time. Again, very high risk women veterans who enjoyed that face-to-face support of hearing each other's struggles and trying to stay tobacco free. And that program dropped to where only 2 to 4 patients are coming right now. The most I've had since the pandemic is 5. My virtual group that was on a video conference, it was very small and growing at the time of the pandemic, and it has now increased. The video conference that we had set up, we call it VA Virtual Connect. But my telemedicine group using the virtual medical center, we grew. No one dropped out because nothing changed. They stayed at home and got their high quality counseling and support and connection to our tobacco treatment program, just like they always had. So that convinced me the first month when I tried to re-scramble and pull back together all the resources that my patients needed just in my tobacco groups, let alone all the other groups we had, that the virtual medical center had something tremendous to offer in addition to those who like participating in a video face-to-face, a visual video face-to-face group. And both of those are, what the VA is trying to promote and use for our populations now. What I'm trying to do in my GIF program is to show that the outcomes, and that's kind of hard to do, that your outcomes are just as good as what used to be face-to-face encounters or video-to-video tele-encounters in a virtual setting where you really don't see someone's expression on their face. The avatar's face doesn't change, but the avatar moves its arms and interacts in other ways and walks and turns around and can run, etc. But that's really what I'm going to be so excited to report in about a year and a half. We're in our first pilot phase in phase 2. We're moving into phase 3, which is where we'll be running all the groups in our new Performance Health and Wellness Center. And as with all of the other pilots that have shown good effect and good feasibility and acceptability and usability by the veterans, now we're excited to be able to show the response of active duty service members and veterans to participating in all of these risk factor groups: diabetes, hypertension, obesity, addiction medicine, and the group education that we'll be running in addition to the self-directed learning. So it's very exciting to be sitting where I am right now and having this technology being evaluated way up at VA headquarters as to whether this is going to be their new technology along with their other existing services that they provide.
Yeah, and I think in the pandemic, if this continues on for another year, having an avatar and having a break from Zoom is probably going to be an interesting option for us. So there's a question from the audience that came in also. If you could talk about the greatest surprise for you in working in public health outside of the US versus physically inside the US, and in particular with the virtual reality space. So if you're in Cambodia and then the US and then in virtual, what commonalities did you actually see across the 3 different formats?
So in 2001, we only had the internet to communicate with our pupils, our participants working in the Ministry of Health. We did not have video conferencing. That would have been wonderful and would have afforded us a tremendous advantage staying connected to them. But we only had email and occasional telephone calls with our participants. But we physically went there for 2 to 4 weeks at a time, mentoring and working with them as they took time off work to learn from us. I'll tell you, the biggest surprise I had working internationally in tobacco control is understanding that in Laos and in Cambodia, they use the Khmer language. There was no word for addiction. And I thought, oh dear, how do I teach them about tobacco dependence and addiction and withdrawal symptoms when they don't even have a word, a native word for addiction? So the cultural issues of teaching in a formerly communist and currently communist country in Laos, and our Western style of teaching, that took us a while to negotiate that. We'd say, does anyone have any questions? No one raised their hand. They think that's an insult to question the professor. So learning how to sit and what's the proper way to introduce yourself and shake hands, all of those cultural norms was a tremendous steep learning curve for us. But we ended up at the end of our 5 and 6 years having tremendous friendships develop and tremendous exchange of cultural perspectives on tobacco control in their country. We linked them to the World Health Organization Tobacco Control Initiative. And I have to say, it's delightful to see what they've done in regards to taxation and imaging and of messaging to the public and warning messages on their products. It's just been wonderful to know that people in Cambodia and Laos are better protected now because of that opportunity that Fogarty gave us.
Great. So one final question, and then I'll have some closing remarks to thank our speakers. So in your words, how can preventive medicine physicians fill the gaps across our country in the healthcare gaps that we see across the country?
So understanding a population, that's really my key. That's what we are taught in preventive medicine. We aren't taught what is chief complaint medicine. A patient walks in with a chief complaint, a doctor figures it out, gives a treatment, the patient leaves. That's clinical care. Clinical preventive medicine also treats individuals, but clinical preventive medicine is the newcomer on the block compared to the history of preventive medicine with population health and public health, and our understanding of epidemiology, biostatistics, health behavior change, and population statistics of, where is the gap in healthcare? How do you identify it? And then what can you think of to help change that? That's what someone in public health and preventive medicine really does. And I would wish that every one of the 170 VA hospitals had a mandate to have one preventive medicine physician helping the leadership who doesn't have that kind of training and perspective to pull into place what we've been able to do at the VA hospital. I'm grateful that there's about 40 that have gotten their foot in the door, but it's not universal. And I'll just tell you, last year I had a staff member leave and I had to shut down a clinic and send people to the community to get the care we provide in clinical preventive medicine. They couldn't find people in the community because the VA didn't even have a definition of what a preventive medicine physician did. So they couldn't even create the contracts to find someone in the community to do what we were doing at the Loma Linda VA. So that was a real eye-opener of how uninformed people are about the specialty of our career within the VA, where I've been working for 37 years.
That's just remarkable. So clearly, I just want to thank you so very much again for your passion, all the breadth and depth of information you've shared. Dr. Krause Wood, Dr. Purnell, Dr. Linda Ferry, the three of you have just been remarkable today. We've had an extremely interesting 90 minutes with three incredible preventive medicine physicians, and I hope you found the presentations to be an insightful window into the day-to-day impact preventive medicine physicians make in their patients, communities, and the general health of populations. If you have any further questions about the work of ACPM or our three presenters, please, please, please do not hesitate to get in touch at the contact information that you see here on the screen. Thank you so very much. Thank you for all the amazing staff behind the scenes. Thank you to our amazing speakers, and thank you to you, our audience, for taking time from your day and for engaging with us for the past 90 minutes. Hope you've enjoyed it. Thank you so much. Have a blessed day.